ఇది కూడా నాకు సరిగా రాసేసినాను కూడా ఇంకా నీకు ఈఆర్సీ అందరూ మీటింగ్ అవుతున్నాను ఇంకా అయిపోయిన తర్వాత హాఫ్ అన్ అవర్.
We're good to go.
Hello and welcome in today's nursing webinar session. Myself Shanti, and we're going to talk about the nursing perspective on IBD. As you all know, World IBD Day is indeed observed on May 12th, May 19th, and every year with the goal of raising awareness, we have chosen this topic. And we are very privileged to have Dr. Naveen Garu with us. Dr. Naveen, please unmute yourself. Yeah. Who is Dr. Naveen is from Hitec Yashoda unit, and he's our very senior consultant gastroenterologist, liver specialist, and endosonologist. I welcome you, sir.
Thank you for having me today.
Thank you, sir.
Good afternoon.
And let me also welcome the charismatic Pompa, who is our senior nurse manager from Hitec Yashoda unit. I welcome you, Pompa.
Thank you so much, ma'am.
Yeah, you can share the first slide, and we would like to quote a first awareness from our end. Go to the IBD slide. Yeah, is there, before we go into detail, we would like to understand that, is there a cure for inflammatory bowel disease, sir?
The inflammatory bowel disease, I'm sure Pompa will go through the incidence and the prevalence of the IBD. What I tell to my patients is inflammatory bowel disease is like somebody who has got diabetes. So when somebody gets diabetes, it is a chronic disease which is going to be staying with them for the rest of their life, right? So there are medications to control the disease, but there are no medications to completely eradicate the disease, eradicate this chronic inflammatory bowel disease. Okay, so it's very important to educate the patients that it is a disease which is going to stay with them for the rest of their life. All we're going to do is try to maintain control or keep the disease in remission. Is what we call remissions. In other words, keep it inactive state. Yeah.
So let us see what we have in rest of the session. Over to you, Pompa.
Yeah. Thank you. And thank you, ma'am. Good afternoon, everyone. My name is Pompa. And today, thank you so much for joining with us for this session. And let's discuss about today's topic on IBD, which is called inflammatory bowel disease. It refers to condition. One is Crohn disease and ulcerative colitis that are characterized by chronic inflammation of the GI tract. So we'll discuss a brief about ulcerative colitis. It's basically affects the colon and characterized by the inflammation of the mucosal layer of the colon, as we can see in the image. Next is Crohn disease. It involves any component of the GI tract. It can start from the oral cavity to the anus. And here in this, it's affect the transmural inflammation. What is the transmural inflammation is? It's caused the thickening of the bowel wall, and it also causes the lumen to get narrow, but not on all cases, but yes, for some cases.
So, sir, here again, the awareness about, is inflammation present from the beginning for IBD?
Yeah, good question. See, I think first we should probably discuss about, as Pompa says, the inflammatory bowel disease is divided into two characteristics.
Yes.
One is the ulcerative colitis, another is the Crohn's disease. I'm sure all of you, the nurses and the audience, may have heard of these names before also.
Yes.
So the difference between both of them is the Crohn's disease affects everywhere in the GI tract, right from the mouth to the anus. So mouth, esophagus, stomach, small intestine, large intestine. It affects every part of the GI tract, the Crohn's disease. Whereas ulcerative colitis only affects the large intestine. It doesn't affect the small intestine or the stomach or the food pipe or the other areas. Yes. So it is that's one important point. Okay. And the other important point is ulcerative colitis only affects the lining of the inner lining or the mucosa of the intestine, of the large intestine. Whereas Crohn's disease, it affects the inner lining, it affects the muscle layer, the fat layer of the GI tract wall. So in other words, because it affects the muscle layer, you start having fibrosis, scarring, fistulating disease, stricturing disease. These are all the components or the consequences of having this transmural inflammation.
Inflammation,
okay?
Yes.
So that's what the difference is between both of the Crohn's and the ulcerative colitis.
Yes. So look after what are the potential risk factor and the causes. The exact cause of IBD is still unknown, but yet there are some family history. 5 to 20% of family history having the first degree like parents, childs, and siblings. Then genetic, which we'll be discussing later slides. Diet, smoking is, again, cigarette smoking is one of the most important controllable risk factor for developing Crohn's disease and GI infection.
So, sir, are these the potential risk factors or causes for the development or to begin with the IBD, sir?
Yeah, absolutely. As Pompa says, they're quite right. There are, see, the causes of IBD are still not very clear, or the pathophysiology rather. But what we know, what I tell to my patients is, so they'll ask us the questions, isn't it? What is IBD? Why did I get this IBD? Why did I get it now? Okay. So it's like our own soldiers of the body, which protect us from outside infections. If they start sensing or treating that the lining of the intestine itself is an outside organ, our own immune system working on us. It's like an autoimmune process. Okay, it is a simplified way of telling. There's of course quite complicated because there's a lot of pathways which are involved. But essentially, somebody who has got genetic abnormalities, then on top of that, if you have environmental factors which start making our soldiers imagining that the lining is itself is an outside organ, then it starts damaging our own intestines. That's where all this inflammatory bowel disease starts. There are a number of studies which actually looked at the environmental factors also. For example, there was one study from Japan, these Siamese twins, so which means they have genetically the same composition of those twins. One twin lived in Japan, the other twin was living in US.
Oh.
Okay, so they did a comparison to study to see which other people who actually have increased risk of IBD. So people in America, the Japanese twin who was in the America, they had higher incidence of inflammatory bowel disease compared to the twin who was in Japan.
Who was in
So,
Japan, yes.
yeah, so it also tells us that along with the genetic factors, there are environmental factors which play a role in triggering this inflammatory bowel disease. Now, smoking is another important factor because smoking almost increases the risk of developing Crohn's disease by almost 55 times. So, some things which are in our hands, which we can control,
Yeah.
Crohn's disease is definitely smoking. So, we definitely need to stop. And not only that, it also increases risk of cancer in the colon also because of the smoking.
Yes.
So, is it pediatric age of group? Is it increasing? So, approximately 5 to 10% of patients develop IBD in their childhood and adolescence.
So, sir, as Pompa was mentioning, is pediatric IBD increasing as it may be very difficult to manage their symptoms while they are at school, especially the young kids and adolescent.
Yeah.
So, what is your take on this?
Sadly, I think all the nurses and everybody should be aware of this inflammatory bowel disease because sadly this disease is on a significant rise throughout the world, particularly in India. Previously, when I was studying in India before I went to UK, we hardly saw any IBD patients. I'm talking about 1995. Okay. During the time, there was no IBD at all that I could see. In fact, all IBD that I read about was from textbooks only. But after I went to UK, I saw a lot of patients of IBD in UK. And then when I came back from UK, and I started seeing so many patients of IBD in India. So, and over the last 10 years, we've seen a significant rise in the number of IBD patients. In fact, India is the second most common country which has got IBD second next to the Western countries. Okay, so India IBD is just growing quite significantly. And sad part about this IBD is it affects the younger population.
Yes.
Okay, so that is the reason why pediatric population, adolescents population, that those are the most common population which gets affected, and that is the reason why. Now, see if you can imagine a younger boy, as Pompa already mentioned, a kid who doesn't know how to express their symptoms, who doesn't know how to tell what is going on. They suffer with a debilitating disease which is going to stay with them for the rest of their life. And you can imagine how much of mental, psychological, physical damage that will cause on these patients. That's why in our IBD clinics, we always have a psychiatrist and a counselor with our clinic. That's an MDT meeting that we should all have, a multidisciplinary team meeting where there will be a nutritionist, there will be a psychiatrist, counselor, and the IBD specialist doctor, the gastroenterologist, who actually sit in the clinic and then deal with these patients.
Yes.
Because it's very difficult to treat in adolescents because There's so many different things which overlay and interplay between them to actually cause this debilitating disease.
And they do not easily communicate, neither with the parents and nor with the outsider. And
Absolutely.
they cannot even cope up. So,
Absolutely, and they
yes,
have a stigma from the from their peer pressures, from their
peer
friends,
pressures, yeah,
from
they're
the
shy.
friends. Yeah, they feel shy going to the toilet. Uh, Even the teachers sometimes don't understand what is going on with the child. So it's important that we educate all the people who have been involved in that boys or girls, in that adolescents or the kids' care. To be honest, that's why it's important that we should work as an MDT and work towards making them understand. See, uh, the more you empower your patient, your parents, and your kids, they will be able to better control the disease.
Yes,
So that's
they'll
where it's very,
report.
very important. Yeah.
They
So,
report.
yeah,
They'll
absolutely.
report. Yes. Yeah.
So we'll see next slide, sir. Was there any connection between the IBD and the immune system? Basically, IBD is an autoimmune disorder. The body's immune system attacks the body's healthy tissues. The risks are environmental, infectious immune, and bacteria in the gut.
As you have already mentioned, due to weakened immunity, this or maybe a primary GI infections may cause this IBD, sir.
Yes,
Yes.
yes, yes, yes. So it's like, as I said earlier, I think we
Yes.
discussed it already, the autoimmune. So some environmental factors or infections will trigger our immune system. That immune system cascades to have multiple pathways which cause inflammation. That leads to the damage that we see.
Yes, sir.
So again, the risk group are all, which are the risk group for across all the ages. So here, yes, the peak incidences are found mostly the age group between the 15 to 30 years of age. So
So,
as
sir,
we said,
is this the true study that 15 to 30 years, or which group it is among peak incidence is raising up?
So, as I said earlier, it is generally seen in younger population. But for the Crohn's disease, we have bimodal distribution. In other words, they have two peaks. So one peak is around adolescents to up to 30 years. Then they have another peak between 50 to 60 years. So these are general population where we see increased incidence of the Crohn's or the ulcerative colitis. By
Yes.
the way, I think we're probably going to discuss about the symptoms, right, of the
Yes, yes,
Crohn's.
we are heading towards.
so
Yeah.
then what are the signs and symptoms? Again, gastrointestinal symptoms, like obviously the patients will have the diarrhea, bloody stool, abdominal pain, growth failure, which is a very common feature, especially with the patient with the Crohn's disease. Physical findings, abdominal tenderness, especially the right lower quadrant, fistula, anal skin tags, fissures. Systematic symptoms, fevers and fatigues are very common during this flare of disease, and some extra intestinal manifestation like oral ulceration, clubbing, rash, jaundice, hepatomegaly, and arthritis, which may also cause it. The diagnostic evaluation.
Just
The
a minute,
diagnostic,
Pompa, just go back to the eighth slide. Eighth
yeah.
slide. Yes, sir. And are these signs and symptoms at initial stage? Maybe you
Yeah.
witness a lot of patients coming with these sign symptoms. Would you acknowledge your thought process on this?
Yeah. So typical presentations are, patient having bloody diarrhea. Okay, and they have a lot of tenesmus. In other words, they want to keep going to the toilet regularly every
Yeah.
time, having that urgency. They can't stop themselves. They have want to keep visiting the toilet very, very quickly. So urgency, tenesmus, and also bloody diarrhea are the common features in ulcerative colitis. In Crohn's disease, along with this, you can expect to have abdominal pain, and if it is a long-standing problem, then you can have weight loss. Sometimes they can have a severe disease. They can have fistulating disease. In other words, you have discharge coming from around the anus, what we call perianal fistulas, or you can have fistulas coming to different tracts also, like into the bladder, into the uterus, or even to the skin also, or between intestines also, what we call intestinal fistulas,
Yes.
or a enterocutaneous fistula, or enteroenteric fistulas, or enterovesical fistulas. So these are different types of fistulas depending upon where the track is. They can also form these kind of fistulas. And of course, as Pompa already mentioned about the extintestinal manifestations, just recently we had, in fact, today only we had one patient who he started presenting with arthritis. And when we actually evaluated, he also, today we did a sigmoidoscopy for him, it actually picked up that he's got colitis. So there are joint pains, particularly small joints, Okay, uveitis, eye irritation,
Yes.
liver issues, like as you said, clubbing. All these things can also be manifestations of the inflammatory bowel disease.
Thank you. Next is diagnostic evaluation. Basically, will be the doctor on the initial assessment. They will be doing the thorough physical examination, history collection, colonoscopy, endoscopy with biopsies, ultrasonography, stool sampling, some blood test, especially for the IBD biomarker, ASCA and ANCA, which signals the inflammation.
So, what are the current best practices or therapeutic options, sir? Like we keep hearing about a lot of things about like POEM and ERCP evaluation for such cases.
Yeah. So IBD, basically the whole idea of treating these patients is to control the inflammation. So we want to make that as an inactive inflammation. Okay. So as I said earlier, we cannot remove the inflammation, we cannot eradicate the inflammation, but we can control and make it inactive. Okay. Further, there are different type of treatments and medications. Generally, there are two types of things, what we call step up treatment or step down treatment. So step up treatment, in other words, you start with, if it is a mild inflammation only, then you start with lower doses, lower potency drugs, and then you go with the next, then you go to higher potency drugs or stronger drugs, which include sometimes injections called biologics. If that fails, then you go for a surgery. But most of the times, medications should control the disease. Very rarely we go for surgeries for these kind of conditions, particularly for colitis. Step down is when you have very active disease, you start with strong medications, and then as the disease gets controlled, we come down on the treatment. So there are different types of options that
Treatment
we have,
regimen. Yes.
regimens that we have. But important thing that we need to always understand is we need to keep the disease inactive, under control, because otherwise inflammation continues, and obviously complications develop, including in the future there's also risk of developing colon cancers for these patients. So you always need to keep
And
them.
other organs are also targeted.
Yes, absolutely.
Yes, so very good to acknowledge and understand step up treatment and step down treatment. I think we all must, have such kind of webinar to have the opinion and expert from your, communication. Yeah. Next.
Thank you, sir. So treatment, the goals of the treatment IBD includes the future flare-ups, how to stop it. So medication, surgery, dietary management, lifestyle changes. Medication is a key point to treat the IBDs as prescribed, especially for the Crohn's disease. Here, the medication specially used are immunosuppression, steroids, topical anti-inflammatory, analgesic, and antibiotics.
So, sir, how safe are these IBD medications? Because one has to consume for long term, I guess. And
Yeah. Very good question. So as I told you, this disease is going to be staying with the patient for lifelong. Obviously, we will have to give medications. So all these medications will have some side effects. So we need to be cautious about how we're going to give medications, what we need to give medications for. So for example, steroids, we can't give for long term, as we know, because it's got a lot of side effects.
yes,
Including along with weight gain, you have bone thinning, blood pressure problems, so many other problems that people come with the steroids. We can't give steroids for long term. So that's why what we call a steroid sparing immunosuppressive drugs, like azathioprine, 6-mercaptopurine. So all these drugs don't have the same side effects as the steroids, but they have different type of side effects. Like these drugs like azathioprine can cause irritation to the pancreas. It can affect the liver. It can affect the bone marrow.
yes.
So we check for those blood tests regularly to say that, to make sure that all these organs are safe, and then we continue to increase the doses, appropriate doses, till we get a therapeutic levels of those medications. So that's what we try to do. And along with that, we have other 5-ASA preparation medications, which also are they have less side effects, but those are the medications which will help us to treat the conditions. Then we also have biologics. So all these injections or medications and tablets will have side effects. We need to always look at the risk benefit ratio, and then suggest what is the right treatment for that patient, keeping in mind that the whole aim of all the treatments is to keep it inactive. So previously we used to say inactive means patient doesn't have a symptoms. That is what we used to call as inactive state, or in remission. Okay, in clinical terms we call remission. But now we don't talk about just clinically no symptoms, but we also look at endoscopic remission, Along with that, we also see histological remission. In other words, we call deep mucosal remission. So DMR is one short form what we call. So we want to always achieve deep mucosal remission with these
Remission.
medications so that we can control the disease.
Yes.
Thank you. The surgery part, surgery it depends on the individual patient's condition, colectomy, protectomy, ileotomy, cholecystomy, abscess, drainage, fistula repair.
I think these are the procedures, as you said, if at all patient has line, complications, then you all need to intervene on this, sir. Yes.
Yeah, absolutely.
IBD diet is also plays a very important role for patient with IBD. Mediterranean diet, which includes rich fresh fruits, vegetables, whole grains, lean proteins, healthy fats, carbohydrates to eliminate something, food to eliminate which triggers the symptoms, and regular screening for the nutritional deficiencies such as vitamin D, iron, B12, which needs a regular screening.
So, sir, patient commitment towards following this diet and lifestyle changes, I think that will really, give the good effectiveness on their disease condition.
Yeah, this is always a difficult thing because it's difficult to control patients' diet.
Yes.
No matter, despite whatever we give advices to them, there's always a lacking in this. But yes, as we know that inflammatory bowel disease affects the intestine. Intestine is where all the nutrients gets absorbed. So if there is
Yes.
inflammation in the gut, then obviously you won't absorb any of these nutrients. Okay, so and that's why people start losing weight and all the other complications they develop. So it's important to control the disease, but at the same time make sure they have a good nutrition so that minimize the risk of the flare-ups for these patients.
Yes.
Obviously, as Pompa said, we always need to check for the vitamin deficiencies, and then you have to keep replacing it whenever it is needed.
Nursing management, patient education, pain symptoms, pain and symptoms control, mental health support, coping skills, then dehydration, as there is a history of diarrhea, nutritional, and important of timely medication. As medication, they have to continue, as you said already, that for the lifelong. So consumption of timely medication is also very important. Follow-up care and stomach care during hospitalization. As if it is a post-op care, the stomach care has to be follow-up, and even health education for the patient going home with a stomach.
I think, sir, yes, these are the points where our nurse should educate whether the patient is in OPD or IP.
Absolutely, absolutely. So as I keep saying, this is a lifelong disease for them and affects younger people. So which means they will be having this for lifelong, for longer number of years, really. So they'll have a lot of these mental issues with it, psychological issues, coping skills, irritability, and all these things are we see it often in our patients with IBD. I think we should be very sympathetic and empathetic towards the patient. All of us as a team members, doctors, healthcare staff, nurses, we all should understand that this disease is going to be there for lifelong with the patient. So we need to be more empathetic and sympathetic to them. And we should understand what they are going through. Then only we'll be able to help them out in all these kind of coping strategies. And a lot of times if they have pain, we may not be able to give a lot of painkillers because that can affect or flare up or cause more damage to the Crohn's disease. So options of painkillers are also limited. So that means patient will suffer for a long time with a lot of pain, which is also not good. So we have to keep supporting them in different ways so that we help them out with their symptoms.
Yes. And that's how we have, Pompa, are you there? So we have come to the end of the discussion, sir. Would you like to provide your final thought as the IBD awareness and prevention?
Yeah. So first of all, as I said, thank you very much for having me today on this webinar. I think it's very important, and it's a very good initiative by you guys to educate nurses and the patients as well, because this is a very important aspect. And as I said earlier, we're seeing increasing number of IBD patients in our clinics. So it is important that we understand about this disease, we understand what symptoms, what problems they will come, and how to solve those problems. And I think that's what we discussed. It's a very good webinar that we had. I think we discussed through the journey of the IBD, what are the types of IBD towards, what are symptoms, and then how to diagnose it, and how to treat them, and how to actually support them, how to manage them. So I think it's a very holistic way of actually discussing what we discussed today. So please do read about it, IBD, because
Yes.
it's very difficult to cover all of it in just in one small in a webinar. So please do read about it because a very important topic which you will be seeing in your lifetime more of these patients. So it's important that we get empowered with this IBD and how to manage these. So you had to tell your patients that it is a lifelong disease. We can only control this disease. A typical example that I give is, as I said, diabetes or hypertension. Once you get it, it won't go away. It will stay with you for the rest of your life. So, making them having a patient education is very important. That there are medications to control it. They need to see the IBD specialist so that we can do either a step up treatment or step down treatment based on the level of the disease. And the aim of all the treatments is to control the disease so that I can have a happy life. And having said that, a lot of patients who actually have a come for regular follow-up, take the medications regularly. If the disease is under control, they have a completely normal life like any of us. People would not even know that this patient has got IBD unless you tell them. Those are the kind of patients we see them regularly in our community, in our clinic. So I think that's what we should aim for all of us as nurses. I think we should work towards that our patients' well-being and patient getting better
Yes.
with IBD.
It is very high time that nursing and these students and the learners and viewers, now since you know the prevalence of IBD is very, very high globally. So this is the high time we should raise the awareness. Many times, I think not the patient, even the patient, healthcare professionals, workers, lot of patients, lot of people, they do not know whether they're suffering with, IBD. So get diagnosed before it is too late. And for your commitment and engagement, it is always important to get follow-up with the doctor. Do not take any over-the-counter medication. And that's how we end the session. Thank you so much, sir, for
Thank you.
your valuable contribution. We end the session.
Yeah.
Thank you.
Thank you. Thank you for having me.